It's about 11 months since we did the procedure in June of last year. So how are things going for our patient?
Okay, so disappointingly, our patient failed to respond to the renal denervation procedure. Now, that's not unusual because we know from the original trial data that there is approximately a 15 to 20% non-response rate. So we're pretty disappointed to say that the patient that we followed for this really didn't respond, and his blood pressure hasn't really come down at all following that procedure, despite the procedure being a success and being done very safely. And we are seeing that. Our current experience in our centre is that we're seeing about a 50% response rate. And one of the great questions left for RDN or to be resolved is which patients are going to respond and which patients don't respond and why. So we're seeing about the real life experience for us is that about 50% of the patients that we're treating, we are seeing a meaningful response in their blood pressure over about between 6 and 36 months following the procedure. The procedure is extremely safe, and that's borne out in all the trial data that exists on the procedure. In our hands, the only complication we see are to do with the access site, in that we're obviously using a 6 French femoral puncture and we're heparinizing the patient. So we've seen one hematoma of the groin, but nothing else at all. And since we've done that, we've taken other moves to mitigate for that complication by ultrasounding the femoral artery of each patient, and so that we're delivering the sheath now under ultrasound guidance, which for a cardiologist is a new thing, but it mitigates the need just to press following the procedure. It means that we can deliver a vascular closure device at the end of every single procedure. We're obviously disappointed that we're only getting a 50% success rate, but obviously, when you translate clinical trial data to the real world, you always see a loss in efficacy to some degree. We're hopeful that it will continue to use the therapy for those people who are extremely resistant hypertensive, for which there is no other alternative. And the fact that we're giving people a 50% chance of really getting even a slight reduction in blood pressure should translate into a benefit in the long-term outcome, although that trial data doesn't yet exist, and it's one of the other questions that's left out there. We're seeing that the response can take up to 36 months to occur, so it may well be that for our patient that we're too early in our assumption that that the patient has been a non-responder, and that's also replicated in the original trials HTN1 and HTN2. The cohorts are still being studied, and we're now 4 years from the beginning of that, and we're still seeing a continual drop in blood pressure in a significant number of those patients. So the effect is certainly not immediate, and it may take up to 36, maybe longer, months to see the full effect of the procedure.
Okay, do you think that explains perhaps some of the findings from HTN3?
Yeah, so HTN3 was the first study to use a sham arm. So the previous studies, HTN1 and importantly HTN2, were randomized controlled trials. They recruited only patients with resistant hypertension whom had secondary causes of hypertension excluded. But HTN2 did not have a sham arm, so people were randomized to just medical therapy or the RDN procedure. So HTN3 was a new and different trial design where people underwent a sham procedure. And they were randomized, over 500 patients were randomized into the study, and they showed that actually there was very little difference when you included a sham arm into the study between the resulting blood pressures at 6 months, and that applied both to office pressures and to ambulatory blood pressures. So a negative study, and that's caused a lot of head scratching in the RDN community, and it's raised a lot of questions about whom would benefit from the procedure, why people aren't responding in a certain way, how do we monitor compliance in patients, and all of that the medical communities are discussing the results of that trial currently.
Okay, and what do you see as the future of this procedure? In your experience, where were you, say, a few years ago? How have things developed, and where do you think things will go after these results have come out?
I think we'll continue doing the procedure. I think research work certainly needs to be done to answer the important questions with regards to the procedure, including who it benefits, Whether the denervation procedure itself has been successful, because there is no way of being able to tell that live as you do the case. There are new technologies, there are different ways to develop the denervation therapy. All the trials, the larger trials that we've been looking at have all been with a single device, the Medtronic Simplicity catheter. There are now 4 or 5 companies in the market with new, possibly better catheters who are all undergoing evaluation as we speak. So the way I think this is going to go is I think that we'll continue to deliver this therapy for those with resistant hypertension, because the registry data and the original trial data suggest benefit in them, and there is there's no safety issue. Okay, and there's no alternative for these people. I think we need to become a lot better at picking the patients in which we think there's going to be benefit. So at the moment, there seems to be a question mark over whether Afro-Caribbean hypertensive benefit as much as Caucasian. And there's a big question mark over diabetics and patients with renal dysfunction as to whether these people really truly benefit from denervation therapy. The other important aspect of this is how do we evaluate compliance, because compliance is a very difficult thing to prove or disprove in our patients, and that will also play a role in how we go forward with this new technology. We don't know what the timescales are going to be in terms of a patient responding. In terms of the development of the therapies, I think over the next probably 12 to 18 months we're going to see more trial data appearing. We're going to see some more maybe bench studies or very patient-specific studies coming out to help guide us as to who's actually going to benefit most from the therapy. In light of HTN-3 and the real question mark over the real degree of benefit that we're offering these patients.
Okay, so you see a positive future for RDN?
Absolutely, absolutely. I think this is the very beginning. And with all of these technologies, and it doesn't just apply to the RDN therapy, the technologies are very basic at the beginning, and with constant work and constant refinement in terms of getting the technology better, the results should become better. And that's how I see this progressing over the coming years. But I think it's going to be a slow process because measuring response is quite difficult. And because of that time lag, organising studies to allow for the late responders is going to be quite difficult and quite a challenge.
And are you involved in any research or in anything like that to do with this field?
So we're looking specifically at the use of RDN in patients with renal dysfunction who are hypertensive and resistant hypertensives. And we don't know whether the RDN therapies are beneficial in these patients, and we're starting to look at these patients and deliver RDN for them to see if we can control their blood pressure. And I know there are other groups around the UK who are also looking at similar kinds of research with very focused patient groups in there. A big question is whether RDN affects people with much milder hypertension. And I know there are plans ongoing and trials being designed to look at people who've only on 1 or 2 antihypertensive medications. So it's pretty exciting times. I'm very optimistic about the future. I think HTN-3 has very much generated a lot of questions for us, but also allowed us to think about which way to go in terms of researching this topic.